Hello everyone, my name is Anthony Ghanem. I'm a second-year otolaryngology resident at the American University of Beirut Medical Center. First of all, I hope that every one of you is safe at home or in their workplace in these unprecedented times. And I really hope that we'll be able to meet up during next year's symposium. Now, the talk that I'm going to present today is entitled The Un-sedated Office-Based Thulium Laser Therapy in Patients with Reinke's Edema. I have no disclosures. So as an introduction, Reinke's edema is an inflammatory disorder that is characterized by the accumulation of gelatinous material in the superficial layer of the lamina propria. The prevalence of the disease is usually less than 1% in the general population, with women being more commonly affected than men. Multiple risk factors have been identified, most important of which are cigarette smoking, laryngopharyngeal reflux disease, and phonotrauma. Now, patients typically present with dysphonia that is characterized by an abnormally low-pitched speaking voice, roughness, and vocal fatigue. Now, other reported symptoms include dyspnea, shortness of breath, and snoring. On laryngeal exam, Reinke's edema is characterized by the presence of unilateral or bilateral edematous changes, or a polypoid mass that is occupying part or the entirety of the membranous vocal fold. And the altered viscoelastic properties of the superficial layer of the lamina propria allow for a range of abnormal sorboscopic findings, most common of which are asymmetry, an increase or a decrease in the mucosal waves, and an increase in amplitude. Now, the goals of therapy are mainly symptomatic relief, improvement of dysphonia, and improvement in breathing. And this was shown in a recent study published by Hamdan et al., whereby patients with Reinke's edema have been shown to have a higher prevalence of obstructive sleep apnea. Now, several therapeutic modalities have been described in patients with Reinke's edema, and starting with simple behavioral modifications such as cessation of smoking and control of reflux disease, in addition to voice therapy, which are the conservative measures adopted at the start of treatment. Now, conventional surgical methods include suspension microlaryngoscopy with either microflap techniques or vocal fold stripping and decortication. Now, with the advent of technology and the improved instrumentation, a large spectrum of office-based laryngeal procedures are now offered to these patients. And these include injections, specifically intralesional steroid or hyaluronidase injection, and non-ablative laser procedures, such as using the KTP, PDL, and CO2 lasers, which we'll dwell upon later on in the discussion. However, there is a scarcity of reports on the application of thulium laser in the management of exudative lesions of the vocal folds, including Reinke's edema. And this is why the authors of this study wanted to report their experience with the application of thulium laser in the treatment of Reinke's edema in an office-based setting. So this is a retrospective chart review of patients who were diagnosed with Reinke's edema and who underwent thulium laser treatment between the months of March 2017 and November 2018 at our hospital at AUB. All procedures were performed in a clinic setting without sedation, and the demographic data included age, gender, smoking status, and grade of Reinke's edema. Now, the grading of the disease was mainly based on Yonezawa classification, which states mainly that grade 1 edema is the one that is limited to the upper surface of the vocal fold, with a normal mobility of the vocal folds and preserved patency of the glottis. Grade 2 is edema extending from the upper to the lower surface beyond the margins of the vocal fold, and the two margins are usually in contact during inhalation. However, grade 3 edema is whenever the edema is more extensive, and during inhalation, only the posterior glottis is open. Now, the outcome measures in this study were mainly the Voice Handicap Index, the GAR-based classification, the extent of regression of the disease on endoscopic exam, acoustic analysis, and aerodynamic measures, specifically measuring the maximum phonation time. Now, this is a brief video on the surgical technique and how we do it. So the patient is usually fully awake and sitting in the upright position. The nasal cavities, oropharynx, and nasopharynx are anesthetized. So topical anesthesia is administered to the larynx, as you're going to see here, by dripping 2% lidocaine through the working channel of the fiber optic endoscope. And after ensuring proper anesthesia, a 0.55 thulium laser, glass laser fiber, is advanced through the same working channel, and the laser beam is applied in a non-contact mode or a contact mode if the edema is quite severe. And the procedure is considered complete after the lesion has blanched, as you have seen in the video. So moving on to the results, the total number of patients included in the study was 11, with 8 females and 3 males. And the mean age of patients was around 51 years. All patients were smokers. 7 out of the 11 had grade 3 edema, and the disease was bilateral in 8 patients and unilateral in 3. Now, a total of 13 procedures were performed, and none of the procedures was aborted or terminated. 2 patients had 2 procedures performed, and these were done at an interval of 6 weeks. Endoscopic evaluation preoperatively revealed grade 3 edema in 7 out of the 11 patients. And following surgery, there was complete regression of the disease in 3 patients and partial regression in the remaining 8. So technically, all of the patients had either partial or complete regression of the disease. Now, regarding the Voice Handicap Index, 10 out of the 11 patients had improvement in the VHI-10 score, with a mean VHI decreasing from 15 to 3.07. And this was statistically significant with a p-value of less than 0.01. Similarly, there was statistically significant improvement in the GAR-based scores, except for asthenia, with a p-value of less than 0.05. Now, with regard to the acoustic analysis, the mean habitual pitch increased by almost 30 hertz from 125 to 155 hertz. There was also improvement in the mean jitter and mean shimmer. However, these did not reach statistical significance. Similarly, there was no significant change in the MPT. And this non-significance is mainly attributed to the small sample size of the study. Now, different types of lasers have been used in an office setting for the treatment of benign vocal fold lesions. And these are mainly the photoangelitic lasers, specifically the KTP and the PTL laser. And these have gained popularity because of their fiber optic mode of delivery and their affinity to oxyhemoglobin, which allows specific photocoagulation of the lesion's microvasculature without damaging the surrounding tissues and the overlying mucosa. Now, less commonly used is the CO2 laser with a higher wavelength of almost 10,000 nanometers. And this laser has a greater affinity to water. And when used in a non-contact mode, it allows the vaporization of the water content within the superficial layer of the lamina propria in Reinke's edema. Now, the literature is scarce on the use of thulium laser in the treatment of benign vocal fold lesions. Zeitels et al. Reported on the use of thulium laser in patients with papillomatosis, vocal fold edema, and granuloma. And a year later, Kaufman et al. Shared their experience with thulium laser in patients with granuloma, amyloidosis, and 3 cases of vocal fold lesion. Both reports refer to the superior cutting and hemostatic properties of the thulium laser, and hence the reduced risk of bleeding. Now, thulium laser was shown to be a safe laser that can be used interchangeably with other types of laser for the treatment of benign vocal fold pathologies. And no previous study has examined the use of this specific laser in the management of Reinke's edema in an office setting. And the results of this investigation, of our investigation, are in agreement with those reported using the photoangelitic lasers, as it was shown that there was a significant decrease in the VHI score in 10 out of the 11 participants, with a drop in the mean value by almost 12 points following surgery. There was also significant improvement in all the GAR-based scores except for asthenia, that is commensurate with the regression in the size of the Reinke's edema in all subjects. Now, acoustically, there was a marked increase in habitual pitch by almost 30 hertz, however, with no significant improvement in the perturbation parameters, nor in the maximum phonation time. And as we said, this is mainly attributed to the relatively small sample size of the study. And the results of this study are in keeping with the previous report by the same authors, Hamdan et al., on the application of thulium laser for the treatment of vocal fold polyps, suggesting a wider application of this laser in the management of exudative lesions of the vocal folds, specifically in an office setting. However, we do not advocate Thulium laser as the laser of choice for the management of Reinke's edema, as this is a diode laser with affinity for water and not oxyhemoglobin, which might result in damage to the mucosa. And finally, to conclude, office-based Thulium laser can be offered as an alternative treatment for patients with Reinke's edema, and further research is needed with a larger number of patients and long-term follow-up in order to better assess the efficacy of this treatment modality. These are my references, and I thank you all for your attention.